All right, good afternoon, everybody. Good to see everyone here today. My name is Shalini Wickramathilika. I am a senior advisor in the Office of the Assistant Secretary at the Substance Abuse and Mental Health Services Administration, or SAMHSA. Part of my role at SAMHSA is overseeing our women's health portfolio, and it is a very exciting day today as the Maternal Mental Health Task Force, which is a subcommittee of SAMHSA's Advisory Committee on Women's Services, releases their national strategy to improve maternal mental health, as well as its accompanying report to Congress. I am so happy to see all of you here in person today, and I know lots of folks are tuning in virtually as well. And when I was looking at the registration list, it was really heartening to see how individuals from so many different sectors care about this topic and recognize that maternal mental health and substance use is truly a crisis in the U.S. The Maternal Mental Health Task Force, which is comprised of over 100 federal and non-federal members, has been working incredibly hard for the past several months to develop a comprehensive set of recommendations on how to address this crisis. You'll hear more about those specific recommendations later in the program. The members of the task force are some of the most knowledgeable, dedicated, and passionate individuals in the maternal mental health field. And we are so grateful for the hours and hours they have put into developing these recommendations. I'd like to take a moment to ask all the task force members who are here today to stand so we can give you a quick round of applause. Wonderful, thank you. Thank you all so much for all of the work. The co-chairs of the task force are the Assistant Secretary for Mental Health and Substance Use, Dr. Miriam Delphin-Rittman, and the Assistant Secretary for Health, Admiral Rachel Levine. I think everyone involved in this process recognizes how inspiring and dedicated these two leaders are, and we are so grateful for that. I want to particularly recognize 4 of the rock stars in OASH and SAMHSA who have led the work for this task force at the federal level, Dr. Nima Sheth and Dr. Dorothy Fink, as well as Madonna Green and Dr. Centrise Bellamy. Some other federal staff members who have been integral in supporting the work of the task force include Jennifer Gillison, Summer Brown, Karen Marks, and Amy Smith. Senior agency leadership, including Sonia Chesson and Sarah Boateng, as well as center and office leadership, including Dr. Anita Everett, Rochelle Marshall, and Larissa Washington, have been invaluable. And this work wouldn't have happened without the support of counselors in the immediate office of the Secretary, Rose Sullivan, Stephen Cha, Rachel Pryor, and Meg Sullivan. Let's give the SAMHSA, OASH, and HHS folks a round of applause too. Today you'll hear from several federal speakers about the recommendations from the task force. You'll also hear from Congresswoman Nanette Barragan, who was one of the champions of the Triumph for New Moms Act that ultimately led to the creation of the task force. And you'll also hear from 3 people with lived experience to remind us of why this strategy is so important and ground us in the potential that this strategy has in supporting moms with mental health and substance use disorders. So with that, it's my honor to introduce our next speaker, Admiral Levine, the Assistant Secretary for Health.
Well, thank you very much for that warm welcome. Good afternoon, everyone. I am Admiral Rachel Levine, the Assistant Secretary for Health, and I am truly honored to welcome you to our event celebrating the launch of the Task Force on Maternal Mental Health's National Strategy to Improve Maternal Mental Health Care and the accompanying report to Congress. As the co-chair with my friend and colleague, Dr. Miriam Delphin-Ritten, Assistant Secretary for Mental Health and Substance Abuse, I want to recognize the task force members' dedication and commitment to improving maternal mental health outcomes. As you know, maternal mental health and substance use are the leading underlying causes of pregnancy-associated deaths. Pregnant women with a mental health condition are also 50% more likely to experience severe maternal morbidity. The task force members have worked tirelessly to develop a comprehensive set of recommendations to address this urgent maternal mental health crisis. Their collaborative efforts have provided us with a national strategy and the accompanying report to Congress in less than a year. Your passion and commitment to improving maternal mental health across our nation is greatly valued by HHS and others working in this field, and we look forward to reviewing these recommendations and continuing to work together as we move to next steps. I would like to express a special thank you to those who will be sharing your lived experiences. As medical and public health professionals, we recognize how critical it is to hear your voices from diverse communities. We know sharing your lived experiences is not easy. It's not easy, but your voices do amplify experiences that may not have always been heard. For all people and places to thrive, we need feedback from our communities on what is working and what areas we need to focus on. As advocates, your experiences drive action and help to inform policy that can literally save lives. We appreciate your invaluable contributions to this process and your willingness to share with us. Collaboration is fundamental to all of our success, and the task force effort that brought us to this point exemplifies the synergy found within our collective expertise. As a result of the work of the task force, we have fostered relationships that are essential to coalition building. These connections will be essential as we work to address maternal mental health issues in our nation now and in the future. So now I'm going to turn things over to my fellow co-chair, Dr. Miriam Delphin-Ritten, Assistant Secretary for Mental Health and Substance Use. Thank you.
Thank you so much, Admiral Levine, and good afternoon, everyone. It is just such a pleasure to be here. Admiral Levine, I have to say, it is such a pleasure co-chairing this task force with you. We often say our teams just work together so well. They're like the dream team in terms of collaboration, and so we're really grateful. And to Representative Barragan, who I know will be here, is, I believe, here or on her way. So grateful for joining us. Your work just so positively impacts mothers through the Triumph for Mothers Act, which enables us to strengthen our support for women, for pregnant and postpartum people during their most vulnerable moments. And thank you also, you heard this already, thank you also to the task force members. So Dr. Sheth, Madonna Green, and the OASH and SAMHSA teams, who have been just instrumental in standing up the task force and delivering actionable products. Grateful also for the Advisory Committee for Women's Services for their ongoing work. And this team together really got in the zone and stayed in the zone to be able to deliver this report, which is actionable, comes from a place and informed by lived experience, and so we're grateful for that. And then I also want to thank the inspirational and courageous women with lived experience who are here to share their stories with us. Grateful for their presence and participation throughout our work on the task force. So we know that addressing maternal mental health is an urgent public health crisis. Sadly, the United States has the highest mortality rates among high-income countries. More than 22% of pregnancy-related deaths are from suicide, drug overdoses, and other mental health or substance use-related challenges. Coming together to have these complex conversations is more important now than ever. And since the task force was established in September, both federal and non-federal entities, as well as individuals with lived experience, shared their expertise and experiences to create actionable, collaborative plans to address maternal mental health, substance use, and co-occurring disorders. And I'm so pleased that just a few months later, we've come together again now to announce this first ever national strategy to improve maternal mental health care and the supplemental report to Congress. Yes. The national strategy features a task force recommendations for a whole of government approach to building a necessary infrastructure to improve maternal mental health conditions and substance use disorders. The task force and the report, it calls for seamless integration of perinatal mental health and substance use care across medical, community, and social systems. It underscores the importance of equitable and accessible maternal mental health and substance use disorder health care. And equally important, as the crisis evolves, we'll continue to evolve the strategy. And I think that's an important point to stress. We will continue to look at and evolve the strategy to ensure that it's meeting the needs that come up as we continue to assess what we're seeing environmentally. My colleagues, Dr. Fink and Dr. Sheth, will go into the report in a moment in more detail. But before I pass the floor to my colleagues, I'd like to also take the opportunity to highlight two different 24-hour resources that I'd like to let folks know about and to remind folks about. One, and you'll hear more about this momentarily, is the National Maternal Mental Health Hotline. This hotline provides free, confidential mental health support for moms and their families before, during, and after pregnancy. Thankfully, we have Administrator Johnson here from HRSA who will share more about this hotline, and so grateful for the work that HRSA has done in this space. I also wanted to share about 988, so the 988 Suicide and Crisis Lifeline. Anyone who is struggling and having a mental health or substance use related crisis or any other form of distress can call the hotline 24 hours a day, 7 days a week, and get connected to a trained, compassionate counselor. So I wanted to remind folks of that as well, that if they're struggling, they need not struggle alone, and help and support is available. As we move forward, we will remain committed to promoting maternal mental health as a key component to addressing overall maternal health. Next fiscal year, we're seeking $44 million in funding to support SAMHSA's Pregnant and Postpartum Women Program and $3.5 million in funds to establish the first ever, and we're really excited about this, the first ever Women's Behavioral Health Technical Assistance Center. As I close, I want to once again acknowledge the hard work and innovation that went into the creation of the new national strategy to improve maternal mental health. Thank you again to the members of the task force, to the volunteers, the individuals with lived experience, to HHS staff, SAMHSA staff, community organizations, individuals from other federal and non-federal agencies. You see, this took a village. It took all of us really working together, laser focused on this important goal. I look forward to our continued collaborations, our continued work together. And so now it is my pleasure to introduce our next speaker, who will be Barbara Tunstall, who will share with us her lived experience. And so I'll turn the floor over to Barbara. Or is it to represent, actually, you know what? I'm going to turn the floor over to Representative Barragan, who is here. And so thank you so much for being with us, Representative, and so appreciate your leadership and work in this space.
Well, thank you, everybody. Thank you for having me. It's great to be here today, and it's always great when there's good news. And, you know, when the Congress gets something done, that's always good news. And so we're really proud. I think today, for me, is a big day, and I want to thank everybody here for your dedication and your work on this very serious issue. I just actually left a group of healthcare professionals talking about everything in healthcare, including women's maternal mental health and the importance of addressing it. It has been a long, silent struggle, overshadowed by physical health during and after pregnancy. And this is an issue that not only affects new mothers, but also their children and their families. And part of the story that I just told these healthcare professionals is, even though I never had any children, I felt like I did, because I'm the youngest of 11 kids. And my siblings all had children, a lot of them did, and some of them had them at a very early age. So when I was growing up, I felt like I was always raising a child, but you know, we my sister is a nurse. She helps delivers babies, and I would hear day in and day out her stories of women who have all this prenatal care, and there's a focus on women while they're pregnant, but as soon as that baby's born, the focus turns onto the baby and less onto the moms and their mental health and the struggles. And so I really heard and learned a lot from her as well. So conditions like postpartum depression and anxiety not only affect the mom's ability to bond with their child, but also manage their daily tasks and maintain personal and professional relationships. Now, 20% of new mothers suffer from mood or anxiety disorders postpartum, with Black and Latina mothers experiencing notably higher rates of depression compared to their peers. And I represent a district in Los Angeles, so I often like to talk about what's happening there. In Los Angeles County, 1 in 4 new moms experience maternal mental health conditions, and unfortunately, the majority of women who have maternal mental health condition will not receive treatment. And left untreated, these health conditions will cost the U.S. economy $14 billion annually. And even beyond the cost, we need to think about the cost on the women, right? It's not just on the economy, it's the cost on their lives, it's a cost on their families who have to live with and work with and deal with somebody who is having health conditions and not getting that treatment for it. So the emotional and the financial costs as well to our families and our healthcare systems are too dire. So this maternal mental health crisis underscores the urgent need for immediate investments in services and treatment and support for new mothers. And maternal mental health isn't talked about enough. I do hear it a little more and more now since I'm on the healthcare subcommittee, but it really isn't talked about enough, and especially in Latino communities. When I grew up, now we were immigrants, and so my parents always said, we don't cause a issue over anything, we're just grateful to be here, right? And I was always the one like, no, Mom, we gotta fight back, well, we have rights, right? I was like that person. But even in the mental health space, there was a negative stigma, of that, well, if you can't see, the pain, then it must be in your head, or, right, there was always some kind of negative stigma, and so we really never heard about seeking help or maternal mental health services from a professional. And, where I grew up, which was a huge Latino population in the Harbor Gateway, we just kind of heard that. So that's one of the reasons why I decided to say, what can I do and help and work on this issue on maternal mental health, and why I introduced the Triumph for New Moms Act in Congress, which passed as part of the fiscal year 23 omnibus funding package. And my bill, what we did is, I'm always looking for bipartisan opportunities, because I always say healthcare is not a Republican issue or a Democratic issue. It's a healthcare issue, and it impacts all of us, and we shouldn't really look at it through that lens. So I said, why don't we find a Republican to work with us on this? And of course, as it turns out, my mom had surgery, and her surgeon, said to me, oh, my roommate from medical school is a member of Congress. And it happened to be Larry Bouchon. So I went to Larry Bouchon and I said, hey, Larry, Dr. James Camel? Oh, yeah, he was my roommate. And I said, let's work on something together. And this is one of the things that came from that relationship, was creating this bipartisan bill that would create a critical task force, and highlighted that this issue is really a bipartisan issue, and it's really a nonpartisan issue, as I prefer to say. So we want to help break the stigma around mental health, ensure new moms have the resources they need to overcome these issues, and reduce the health disparities faced by women of color, something that's near and dear to me given my district and a lot of the community that I represent. So with the task force work to identify and to make recommendations to implement best practices around prevention, early intervention, and treatment, we not only stand to save billions of dollars annually, but more significantly, we can help save lives and impact lives, and that's what it's about. And so I really appreciate all the work that you do and are doing, and I appreciate the ability to come in here and just talk with you for a few moments and for the space. And so just know you have a partner in me in the Congress to continue to fight for new moms and doing all we can in the healthcare space. So thank you all very, very much.
Thank you, Representative Berrigan. My name is Barbara Tunstall, and I'm here to share about my lived experience. When I dare to be powerful, to use my strength in service of my vision, then it becomes less and less important whether I'm afraid. That's from Audre Lorde. If you are silent about your pain, they'll kill you and say you enjoyed it. And that's from Zora Neale Hurston. I learned very early about shame and to keep secrets about what happened in my parents' home. They married, I learned much later in life, because she was pregnant with my brother. My father had been raised by a single mother who, like my father, was an alcoholic. He would proudly state he was a functional alcoholic, and we always had plenty to eat. In fact, food became my drug of choice as I developed an eating disorder, bulimia, as a result of the sometimes volatile environment with incongruent messages. I know very little about my mother. I knew that she was an only child, and so when both her parents somehow died before she was 10, she went to live with an uncle, I think on her father's side of the family. She severed all ties with that uncle. My mother died in 2000 at 71. Like her, I severed family ties a few years before she died and didn't attend her funeral. And now, 24 years later, I'm still healing my shackles of the past. I grew up in the 60s and 70s, the youngest of four, where out of necessity both my parents worked, and I received a clear message growing up that had there been readily available birth control, or if abortions had been legal, I would not have been. I was an accident, as well as a drain on the family's already limited resources. As a result, I remember not visiting healthcare providers very often. Both my parents expressed fear and distrust of the medical system, and I got the impression that perhaps my mother's parents had somehow died as a result of medical intervention. She would never talk about that part of her. There were two experiences, though, that I remember that set the stage for my own aversion to doctors and to the current healthcare system in general. My first visit to a dentist was to treat a cavity. Treatment meant, in this instance, pulling the tooth. I couldn't have been more than 5 or 6, and with only the benefit of topical Orajel, the diseased tooth was extracted. I don't remember the pain, only the blood that soaked through all the gauze and that continued on the bus ride home and through the night. Once at home, I was given tea bags and saltwater gargles until the bleeding finally stopped. The second time I remember going to see an OBGYN, Dr. Desbordes, for a pelvic examination at 7 or 8, and to this day I have no idea why I was subjected to such an invasive exam at such a young age, again, without explanation. I often opine that my dogs receive better care at their veterinary visits. Despite it all, I survived. I graduated from college earning associate's, bachelor's, and master's degrees. At 30, I finally launched by moving to Texas. While there, I became pregnant for the first and only time. When I told my live-in boyfriend that I was pregnant, his response was, "Whose is it?" Shocked, hurt, angry, and suddenly very afraid, I went numb. I simply replied, "It's my child." I also think that it was at that moment I decided to have an abortion. I felt such a strong need to protect this being from the feeling of being as unwanted as I felt then, not only from my parents, and also from the child's father. I broke off the relationship, went alone to have an abortion, and told few about it. I am so grateful to have had the opportunity to serve on the Maternal Mental Health Task Force to provide my lived experiences not only of being a pregnant person in a relationship with a partner who was abusive, and also as an adult survivor of adverse childhood experiences, medical trauma, and invalidation where my credibility and bodily autonomy were denied. I am grateful not only to the task force leadership for its strong emphasis on lived experience during this process, and also to the Alliance for Aging Research for their Talk Nerdy to Me training in patient research and advocacy, and HopeWorks of Howard County, whose intimate partner violence recovery programs have been invaluable tools in my ongoing healing. I am grateful to both the Alliance for Aging Research and HopeWorks for their letters of recommendation, which have allowed me to serve on the task force. And I close with Proverbs 29:18, where there is no vision, the people perish. And it is my vision that through our initial work identifying some of the causes that have led to the dismal outcomes that have brought us here today, we will demonstrate a positive change in the effects for pregnant people who look like me. I believe we accomplish this transformation by reimagining our systems of health that make the invisible visible, where denial of previous harms, like those perpetuated by James Marion Sims on enslaved women in South Carolina, my mother's state of origin, by the way, are no longer tolerated, and our voices no longer silenced, shamed, or simply ignored. Where we instead erect more mothers of gynecology monuments, as Michelle Browder has done in Montgomery, Alabama, and we always remember the history so that harms are never repeated. We have the power to envision and create systems of care that are truly pro-life throughout the entire life spectrum in every sense of the term. Thank you for your time and attention. I now turn the floor over to Health Resources and Services Administration Administrator Carol Johnson.
Good afternoon, friends. Thank you for the opportunity to be here with you today. Thank you to Barbara and the women who bring their stories to this work. It takes courage and it takes something from you to share your trauma in a way that can help inform policy for the future, and we're so grateful to everyone who did that as part of the work of this task force and will help us in the work going forward to implement these recommendations. Thank you to Admiral Levine and Assistant Secretary Delphin Rittman, and to the Congresswoman for her leadership, to the staff and the incredible members of this task force. It is hard to turn a task force around in this kind of timeline and get consensus and get it out and get it produced, and so congratulations to everyone on this incredible work. I'm Carol Johnson. I'm the administrator of the Health Resources and Services Administration. I like to say I have the best job in government because part of my job is making sure we have healthy moms and babies. And I've had the opportunity to visit moms and babies across the country to talk about what works, what their needs are, what challenges are going forward. And has already been highlighted, mental health and substance use disorders are among the leading causes, are the leading cause of maternal mortality in this country. So there is work to be done. But what I want to do this afternoon is highlight 5 things that we're doing now, thanks to the support of the President and Secretary Becerra in making it possible for us to tackle this critical issue. First, on Mother's Day 2 years ago, we launched the National Maternal Mental Health Hotline. 833-TLC-MAMA is the 24/7 call or text to English, Spanish, translation services in 60 languages space to have a safe conversation about emotional support needs, mental health needs, about the kinds of things that women need during pregnancy and post-pregnancy. And it's not just women who are calling, family members who are calling, where our partners call. This line has had incredible demand, more than 33,000 calls in the first 2 years with no advertising budget. We have an advertising budget now, and we're going to expand that work going forward. Our goal is to make sure everyone knows that number and knows that there's a place to have these conversations. So if I might ask all of you, if you could go to HRSA, HRSA.gov, there's a widget on our home website that takes you to information about the hotline. You can call directly from that link. If you might share that on your website, if you might visit our page and order some of our posters or other materials and help us get the word out. We want this information to be part of hospital discharge. We want it to be in community centers and laundromats and all the places where people will get information and access to services. 2, we also are about what services look like in the community. We now fund, we're up to 12 states. We'd like to be at 50 states, but we're continuing to work on it with our friends in Congress. In 12 states, we fund what we call our maternal depression and screening program. In those states, we're training OBs, nurse midwives, doulas about mental health services and needs. And in order that they can be better prepared to meet those needs among their patients. But we're not just saying, here's the training, go forth and do it. We're actually providing direct teleconsult for OBs and nurse midwives to connect to perinatal psychiatrists, to connect to ex-fetal, to connect to psychologists to make sure that real-time support can happen during that visit. You know the challenges people encounter in being able to make follow-up appointments, to get time off work, to go to a follow-up appointment, to do all those things. The more we can empower OBs and nurse midwives and others in the maternal health workforce to be able to address the mental health conditions they can address, the better we'll be able to ensure that these conditions are addressed as early as possible. But we also know that what happens when it comes to mental health needs is not just about what happens in the clinic. It's what happens in the community. And that's why we fund Healthy Start Awards in communities across the country, where we're funding community-based organizations to provide that wraparound support to moms in the community. And that includes making sure that we have community health workers and others and navigators who can help people get to mental health appointments, who can help make sure that people remember they have a telehealth visit. If they need transportation, they can get it. These are critical ways that we're helping to support moms in communities across the country. And four, it's not just, it is critically about the pregnancy period and the post-pregnancy period, but this is a lifespan issue. We need to make sure mental health services are readily available to everyone who needs them when they need them. And we at HRSA fund community health centers across the country that are the primary source of care for many people on Medicaid. As you know, Medicaid pays for about 40% of births, in some states considerably higher than that. It is also the primary source of care for people who are uninsured. We treat people regardless of ability to pay. We provide prenatal services in health centers, but it hasn't always been the case that mental health and substance use disorder services are provided there. In the Biden-Harris administration, we've made that a priority. We're working to make it a required service, and we are today have put real money on the ground to expand mental health and substance use services in health centers across the country. And five, I will just wrap with saying it would be a mistake for us to have this conversation and not note what Dobbs has meant to the mental health and well-being of women across the country. And that's why it's so critical that this president and this secretary are fighting to make sure that choices and options are available to women, and that that our daughters don't have less rights than we have, because it is not only about their physical health, it's about their mental health as well. So thank you again to all the members of the task force for the work that you've done, and we look forward to implementing and taking on your recommendations. Thank you all. It's now my pleasure to turn the platform over to my good friend, Nicole Barnett.
Thank you so much, Administrator Johnson. It has truly been an honor to serve on this task force and to have the opportunity to share my personal story about postpartum depression. And I, too, just want to commend the task force for centering this work around those with lived experience, because we all have the collaborative goal of improving maternal mental health outcomes for all women in this country, regardless of their background, their culture, or their particular circumstances. And for me, those circumstances were around 19 years ago, where I was one of the 1 in 5 moms who will experience a maternal mental health condition. I had a 5-year-old, a 3-year-old, and a 3-month-old, and it was around that time that it became clear to me that the overwhelming fatigue and brain fog that I was feeling was quite different than my previous 2 postpartum experiences. And so I reached out to my obstetrician's office, and the nurse told me that it sounded like I was struggling with a bit of postpartum depression, and that I could come into the office and they could likely give me some medication that would help with that. Well, I did not want to hear the phrase postpartum depression. At that moment, it translated into my mind as failure at motherhood. And even though I was a clinical social worker, I was just still resistant. And I thought, no, not postpartum depression. It is not happening to me. I also wasn't very excited about trying antidepressant medication while I was breastfeeding my daughter. And so instead of taking the advice of the nurse, unfortunately, I continued to spiral down with worsening symptoms of depression and anxiety over about a 3-month period. All the while, I was taking iron pills to try to help, as well as thyroid supplements, but nothing really did the job. It felt like ultimately that an imposter had come and taken over my life. My normal, lively, self-confident demeanor turned into someone who was struggling with sadness and was really believing the depression lies that my brain was telling me, which mostly sounded like I was a failure as a mom. And unless you've experienced it, I think it's very hard to imagine how challenging it is for your very own brain to be working against you during a time when you are most vulnerable and you've been given this new little life to shepherd into the world. The depression really felt like I was walking in quicksand. It would take hours to do, seemingly hours to do things that should only take minutes. I can remember washing my face and saying, if you just keep moving your hand, you'll eventually finish. So you can imagine if it was that hard for me to wash my face, how hard it was for me to do daily tasks and to care for 3 small children. The panic attacks would just come out of nowhere with sweaty palms and my heart feeling like it was going to jump out of my chest. And it would be over the simplest things, like just trying to decide what color folders to send my kindergartner to school with. So it was pretty debilitating. And at my worst, I would have a baby gate. And I would gate myself and my children off into this back room. I'd give my older 2 something to play with and just hold my baby in the rocking chair and just pray for my husband to get home. And my incredible husband was doing his best to support me. There were days that I functioned better than others, and so it was just all very confusing. But I soon began to fear that my children were going to be harmed by neglect because I wasn't as attentive to them as I should be as a mother. And so when things got to that point, I decided to try the medication. In a few weeks, I was feeling more like a baseline of myself. I went on to do individual therapy, and then the most important part of my recovery was being part of a phenomenal support group, which was led by another fantastic member of this task force, Adrienne Griffin. And so for about the past 20 years now, I have been part of maternal mental health education and advocacy on a variety of platforms. I never would have dreamed that I would serve on a task force like this, let alone have the dream job of serving as one of those counselors for the National Maternal Mental Health Hotline that Administrator Johnson just told us about. Every day, I get to help women just like me. And so sometimes the worst experiences of your life can lead you to the greatest opportunity to help others. And it may not feel like it at that moment when I was going through it, but I wouldn't change anything for the world, because as we listen to those with lived experience and we work together and problem solve as compassionate professionals, we can turn the tide of maternal mental health outcomes in this country, one woman at a time, one family at a time. So thank you for your attention, and it is now my honor to hand this off to Dr. Fink, who has a new little one herself, and she is the Deputy Assistant Secretary for Women's Health, Dr. Dorothy Fink.
Thank you, Nicole, for sharing your beautiful story with us. It's so inspiring, and every time I talk with you, I learn something new and really think about how we can continue to build our work. So thank you so much. Good afternoon, everyone. We're so thrilled to have you all here today to join us to announce the products of the hard work of the Maternal Mental Health Task Force over these past months. So we'll start off with a little bit of background in terms of how Congress shared language with us to get us to where we are today. And so the Consolidated Appropriations Act established the Task Force on Maternal Mental Health. The task force was launched in September of 2023 and is co-chaired by the Assistant Secretary for Health, Admiral Rachel Levine, and Assistant Secretary for Mental Health and Substance Use, Dr. Miriam Dolphin-Rittman. The task force identifies, evaluates, and makes recommendations to coordinate and improve federal activities to address maternal mental health conditions and co-occurring substance use disorders. The duties of the task force include preparing and regularly updating a report to evaluate the state of maternal mental health programs at the federal level and developing and regularly updating the national strategy. These actions will continue until the task force sunsets in September of 2027. On this next slide, you can see the timeline of the task force, beginning with the launch in September of last year. During the fall and winter, we gathered input from external stakeholders and completed a literature review and environmental scan. The work continued into the new year with listening sessions to receive input from community stakeholders, followed by a lived experience research sprint conducted by the U.S. Digital Services. Through the research sprint, the task force received direct input from those with lived experience. Some of their comments are noted throughout the national strategy. Next, you can see a request for information was published for input from the public, which we greatly appreciated. After receiving and discussing the feedback from stakeholders and the public, the task force used the information to develop the report to Congress and national strategy. These documents were presented to the ACWS for review and approval, and we now have the pleasure of sharing those documents with you today. Okay, so on this slide, you can see a little bit more about the details of the task force. It resides within the subcommittee of the Advisory Committee of Women's Services, or ACWS, within the Substance Abuse and Mental Health Services Administration, or SAMHSA. The task force members participated in 5 work groups focusing on one of the following areas: data research and quality improvement, prevention, screening, and diagnosis, evidence-based intervention and treatment, evidence-based community practices, and communications and community engagement. All work groups included the 3 cross-cutting principles of access and equity, federal collaboration, and trauma-informed care. The non-federal members of the ACWS approved the recommendations of the report to Congress and the national strategy, all really within record time, and we can't thank all of you enough for the hard work that went into this over the past months. Okay, so on the next slide, you'll see that the ACWS is shared by Dr. Nima Sheth, who you will hear from after me, this Associate Administrator for Women's Services, and several dedicated non-federal members who are actively involved in the work of the task force. We want to thank all of you for your guidance and input throughout the process of developing both the report to Congress and national strategy. Here you can see the task force includes representation from the federal agencies listed on this slide. We appreciate all of your time and dedication to this effort. It's really incredible to have agencies across all of HHS and outside of HHS as well representing many areas of the federal government with equities in maternal mental health. Here you can see each of the work groups and the 2 co-chairs, one federal and one non-federal for each one who led the groups. Each work group met many, many times to work hard and develop these recommendations for the assigned focus areas. We recognize and thank the co-chairs listed on this slide. The HHS team at SAMHSA and OASH coordinated the efforts of the task force throughout the process. Thank you to my colleagues for your commitment to this work. I can't really thank them enough. Dr. Bellamy really led, as my senior leader, led the Maternal Mental Health Task Force from OASH's standpoint, and Dr. Sheth and Madonna worked so closely with her from SAMHSA and really brought our teams together in a beautiful way. And they were just incredible to me and really supported me when I had a new baby over the past month. So thank you so much to all of you. Yes, now 4 months, the best thing. While I miss being part of the report development, I'm grateful to all of you who helped to work on these documents and supported me during this time. Okay, on the next slide, You will see the task force's report to Congress and national strategy are an important part of broader federal efforts addressing women's overall health, including mental health and maternal health across the nation. The report and national strategy are aligned with these ongoing activities, which are inclusive of a number of the of things listed here, as well as many other efforts truly to support maternal health across the lifespan. Excuse me. On the next slide, you'll see that the report to Congress outlines the task force findings on maternal mental health conditions and substance use disorders in the U.S., related federal programs and best practices. The report is comprised of 6 sections. Excuse me one second, I'm just going to grab some water. I'm sorry, the DC allergies are overtaking me. I'm very sorry. Okay, so the report is comprised of 6 sections. The first section consists of the introduction, an executive summary, which provides an overview of the state of maternal mental health, as well as the purpose, findings, and work of the task force. The second section describes current data on the prevalence of maternal mental health conditions and substance use disorders, as well as pregnancy-related deaths linked to them and disparities. Section 3 documents evidence-based, evidence-formed, and promising best practices. On the next slide, I'll just share a few more highlights of the report to Congress. Section 4 details federal programs, including services, and describes current coordination, gaps, and opportunities for improved collaboration. Section 5 describes the overarching themes of the listening sessions and offers opportunities for state and local partnerships. Section 6 concludes the report, providing a summary of the national policies and programs related to maternal mental health conditions and substance use disorder, along with best practices that can be leveraged during the implementation of the national strategy. I'd now like to turn over the presentation to my colleague, Dr. Nima Sheth, Associate Administrator for Women's Services, to discuss the national strategy. Thank you all, and thank you for my patience with my voice.
All right. Thank you so much, Dr. Fink, for taking us through the report to Congress. Okay, so I am really honored to be reviewing this national strategy with you all today, which is truly the collective work of this entire task force. I think we should say that at the outset. And I have to say that I'm just in absolute awe, I think we all are, of each and every one of you on this task force. And it has been such a privilege and just such a humbling experience to be a part of this effort. And we're just so excited for the next steps, actually. So just want to say that again. So here I want to just go over the overarching image that captures the national strategy. So you'll see that it has 5 pillars: building a national infrastructure, prioritizing perinatal mental health and well-being, making care and services accessible, affordable, and equitable, using data and research to improve outcomes and accountability, promoting prevention and engaging, educating, and partnering with communities, and then lifting up lived experience that all connect to the center of whole person and dyadic perinatal mental health and substance use care. And then around the outside, you kind of see our cross themes throughout the strategy, so equity and access, federal collaboration, trauma-informed approaches, and culturally relevant support. So those are embedded throughout all of the different recommendations. So I want to talk a little bit about the vision of the task force. So the vision, that this task force worked really hard to put together it doesn't encapture all of the thoughts around, everything that had been thought of, but I think we thought the best way to put that together would be to say that, we'll have a system of care, of perinatal mental health and substance use care, that'll be seamless and integrated across medical, community, and social systems, such that there will be no longer a distinction between physical and mental health care, and that models of care and support will be innovative and sensitive to the individual's experiences, culture, and community. Again, we could have put a million other things in that, but we felt that was the best way to capture, what we would look for in a vision. And in the document of the national strategy, we also have a call to action that we're not covering completely now, but I would encourage folks to take a look at that because it also describes how to better obtain this vision and work towards it. Now I want to talk a little bit about the audience. So the audience primarily is the federal government, so namely Congress, the executive branch, and then the myriad of federal departments and agencies that spearhead a lot of these different programs that all of our leaders talked about today. And we really are emphasizing a whole of government approach, and you've probably heard that several times now. But we also want to say that the federal government's work cannot be carried out without collaborations and partnerships with states, public-private entities, industry, advocates, medical and professional societies, communities, and of course, individuals with lived experience and their families. So this strategy is really also speaking to all of those collaborators and partners and identifies opportunities for them to come together to work on all of this together. So although, it'll often say federal government or Congress, et cetera, it's really calling for that whole community and whole of government approach. Okay, so now we're going to start getting into the pillars and priorities and recommendations. So before we start, I'll just say the task force chose to organize this into 5 different pillars, and then each pillar has multiple priorities, and then each priority has multiple recommendations. And then just to make it more fun, each recommendation has a why section and a how section. And so the why section is talking about the rationale, like why did we choose this? Why are we focusing on this? Why is it important? And then the how section talks a little bit about providing a roadmap of how to get to this recommendation. So it's not supposed to be all-inclusive of how, every single step to get to this rec, but it's how do we kind of provide enough examples so that the target audience has a sense of how to get there. So just keep that in mind as we go through each one. So the first one is building a national infrastructure that prioritizes perinatal mental health and well-being. So under this, priority 1.1 is to establish and enhance federal policies that promote integrated perinatal and mental health substance use care models with holistic support for mother-infant dyads and families from multidisciplinary and interdisciplinary teams. And you might notice some of our wording, it's because we've agonized over the words that go into each recommendation. I mean, I kid you not, just endless hours spent into which word should we choose, how do we make sure this is represented? So I apologize that some of them might be a bit wordy, but we want to make sure they're as inclusive as possible. So you see recommendation 1.1.1, so it's to enact federal laws and align incentives for states, DC, and territories to mirror the expansion, funding, and enhancement of federal and state-level integrated perinatal and mental health SUD care models, again, involving multi- and interdisciplinary teams that extend from pregnancy through at least the first year postpartum, including 2-generation practices, evidence-based screening and prevention, provision of treatment, and linkages to follow-up and support services. And we do comment in the strategy that when we say evidence-based, that is inclusive of evidence-informed and promising, and that's actually called out in the omnibus language as well, but for brevity's sake, we've referred to them as evidence-based, but that is inclusive. So this recommendation calls for the integration of mental health care and substance use care across all relevant perinatal settings. So it's about embedding mental health and substance use care for perinatal populations into these different settings like obstetricians' offices, primary care, pediatrics, emergency room, inpatient, partial hospitalization, NICUs, postpartum units. So it's thinking big and it's talking about the whole spectrum of care. So services embedded in these integrated care models would include everything from screening, prevention, assessment, referral, linkages, warm handoffs, all of that type of care within these different settings, and would include community-based health workers like doulas, cultural brokers, community health workers, peers. So we really want to make sure that that is inclusive. And throughout the strategy, we talk about the role of community-based health workers. I should also say that the strategy is very inclusive of, I know Dr. Delphin-Rittman has mentioned already mental health and substance use, but where possible, we've also incorporated gender-based violence and interpersonal violence, as we see that as an integral issue tied to this. So it does also include that. And then lastly, this recommendation calls for the enactment of federal laws to require coverage of the various components that would allow for this truly integrated care system. So it's calling on expanded coverage of community-based workers, expanded coverage of all the different elements that would support, have Medicaid or other payers support this type of integrated system. Oh, I'm sorry. Recommendation 1.1.2 is to enact federal laws that require the implementation of 6 months of paid family and medical leave and universal child care in all states, DC, and U.S. territories. So in addition to making these laws, or enacting these laws, the recommendation calls for supporting the House Bipartisan Family Paid Leave Working Group and the expansion of child tax credits and child care subsidies. So it goes into more detail. I'm just calling out a few of the things that are listed in the House sections of this. So we'll go to recommendation 1.1.3, which is to establish policies that support non-stigmatizing and non-punitive approaches to screening for substance use disorders, mental health conditions, and suicide in pregnant and postpartum individuals, and ensure access to culturally responsive, evidence-based, trauma-informed, and family-centered care. So this is a big one, and really calls on the federal government and communities and colleagues to follow the many guidelines and recommendations from places that have done a lot of thinking around this already, like the American Society of Addiction Medicine, the Office of National Drug Control Policy, American College of Obstetrics and Gynecology, and the American Medical Association, just to name a few. It also calls to scale up and fund models that work to provide MOUD and non-stigmatizing care, such as the MOM model funded through CMMI and SAMHSA's residential and state pilot postpartum women's programs. So recommendation 1.1.4 talks about investing federal funding to create trauma-informed, accessible, and equitable family-friendly healthcare facilities across the spectrums of inpatient, residential, and outpatient care by ensuring free embedded childcare. So this one is really about providing incentives and supports for states, hospitals, outpatient clinics to create more family-friendly spaces that are staffed appropriately, that have, toys, that have just allow parents to be able to, go to their appointments, and child-friendly play areas and things like that. So it's really, really focused on more family-friendly facilities across the nation. 1.1.5 is to increase the implementation of well-deliberated, clinically sound recommendations, practice guidelines, and evidence-based interventions related to the treatment and support of individuals and mother-infant dyads with perinatal mental health conditions, substance use, and substance use disorders in all relevant healthcare systems. So this is really calling for more collaboration with stakeholders to create training and enhance implementation of these guidelines in federal programs. So it's really to make sure that we're able to, across the board, follow the most up-to-date practice guidelines and evidence-based practices. So now we get into priority 1.2, which is to establish and enhance federal policies that promote perinatal mental health and well-being with a focus on reducing disparities. So again, we're still within Pillar 1, but now the second priority. So 1.2.1 is to expand, enhance, and increase funding for federal programs serving perinatal populations to ensure that mental health, substance use disorder, and GBV screening and preventative services, linkages to timely and holistic treatment, and referrals to the community are all supported and included. So really what this is saying is take the federal programs that we have, any and all that are relevant, and expand them to make sure that we include these topics within existing programs, as well as to build new federal programs that would be focused on this topic and this population. 1.2.2 is to recognize the effects that structural racism and historical trauma have on creating and worsening mental health and substance use disorders, and prioritize solutions for improving racial equity, addressing trauma, and resolving disparities in care. The why section for this details a lot of important histories of structural racism and contributions of that and historical trauma. And then the how section calls for a number of things, but some examples include adding this topic into the respectful care guidelines, supporting research in this topic through various avenues, and then development of metrics and collection of data on racial disparities, enhancing the metrics that we have. 1.2.3 is appropriate sufficient funds to maintain and federally administer the work of the current task force on maternal mental health, to enhance, coordinate, and sustain efforts and partnerships on perinatal mental health and substance use, to establish in future legislation with funding before the 2027 sunset of the task force an ongoing coordinating committee on maternal mental health that includes federal and non-federal representatives. And this is to keep this work going. We don't want this to sunset in 2027. We hope that it could turn into a coordinating committee, which would help to kind of sustain the group versus a task force which tend to sunset a little bit sooner. So that's what this recommendation is calling on. Okay, so now we're going to get into Pillar 2, which is to make care and services accessible, affordable, and equitable. So priority 2.1 of Pillar 2 is implement culturally relevant and trauma-informed clinical screening and diagnosis and improve linkages to accessible, timely intervention and treatment. So the first recommendation here gets into comprehensive pathways around screening. So to improve routine culturally relevant and trauma-informed screening for the presence of an assessment of risk factors related to developing perinatal mental health conditions and substance use disorders, along with gender-based violence, trauma, and social determinants of health, with the provision of appropriate preventative resources, referrals, and linkages to timely intervention in all relevant care settings. I'm sure you're noticing the theme now that we are going across the spectrum everywhere we can. We're not letting anything go. So hopefully you can see that. So this recommendation calls to expand training and implementation and gives more specifics for each through improving technical assistance efforts, enhancing patient education efforts to eliminate stigma, and creating safe spaces to really have conversations. So not just clinical screening, implementing screeners, but really creating safe spaces to have conversations with patients and their families. With regards to implementation, there's a call to incorporate and follow guidelines such as those from the U.S. Preventive Services Task Force and the Maternal Mental Health Leadership Alliance's framework that has an equal emphasis on patient education and screening. I think namely it's the Perinatal Mental Health Education and Screening Project. So as you see, we're really trying to build on existing work, and where possible, we named lots and lots of examples of current models, guidelines, the work that's already going on. 2.1.2 is to clarify, modify, and adopt universal diagnostic criteria that reflect more accurate symptom presentation, range, timing, frequency, and severity of perinatal mental health disorders, and that improve reimbursement for screening, assessment, and intervention. So this is coming from the fact that what is in diagnostic criteria like the DSM or ICD is not sufficient, is limited, that there has to be work to make those things more accurate. So this calls for things like to facilitate convenings, discussions, and partnerships amongst a myriad of stakeholders, research organizations, professional societies, providers, insurers, and then to take time to align definitions and diagnostic criteria through those partnerships and research support and build an evidence base for them. And then also to collaborate with such relevant stakeholders to survey the literature to standardize those definitions, specifiers, and time periods. So now we're in the second priority of the second pillar, to create accessible and integrated evidence-based services that are affordable and reimbursable. So the first one here, 2.2.1, talks about creating federal mechanisms to fund and develop infrastructure that supports innovation in care delivery models for mental health conditions, substance use, and SUDs, as well as GBV during the perinatal period to reduce barriers to more accessible, holistic, and multi-generational care. So this is talking about more flexible patient scheduling, like what makes it easier for patients to get into care, improving telehealth and communications infrastructure, especially in areas that lack that in particular, like rural areas, creating more home-based care and mobile care models, just to make it easier to use innovation to treat the communities that need it the most. It also talks about text messaging and the use of text messaging to make care more accessible. Recommendation 2.2.2 is to improve federal funding and support for implementation of integrated crisis intervention services for perinatal populations and their families, training of the workforce on crisis care provision that is trauma-informed and culturally relevant, and development of infrastructure that leverages the support of state and local crisis systems. So it's, more crisis services, training and infrastructure development around crisis. And this is our primary recommendation on crisis support. So this talks about more programs in crisis intervention, but also pairing crisis intervention with training on best practices for perinatal populations. And of course, we talk about working with 988 and the maternal mental health hotline that was described earlier today to ensure that there's content specific to maternal mental health crises, and that all of the hotline workers are trained in this. So 2.2.3 is to work with states and all payers to help establish financial incentives, including increased reimbursement and support for perinatal mental health and substance use disorder interventions that demonstrate positive outcomes. So this really does call on all payers, including Medicaid, to increase their reimbursement. We know that there's not enough providers that accept Medicaid because of the reimbursement rates. So this is specifically calling that out. It's also talking about how our colleagues in CMS could support states with creative proposals to change maternal health payment methodologies, including alternative payment models, especially those that incentivize upstream care and support to prevent substance use and health and family crises. We also talk about the new regulation from CMS that requires states to compare their fee-for-service payment rates for primary care, obstetric and gynecological care, and SUD services with Medicare rates, and publish their analysis every 2 years, because that can help motivate some. And then we call on the government to implement and sustain more alternative payment models, such as the Transforming Maternal Health model. We know those alternative payment models are happening all over. It's not just in the government. States and other organizations have them, but we do try to uplift the role of APMs here. 2.2.4 is to strengthen the continuity of care in the community by encouraging federal agencies to add requirements to their notices of funding opportunities that direct recipients to collaborate with other federally funded programs and develop partnerships with community-based organizations and regional state programs to expand access and referral to treatment and recovery support services. So this is really calling on federal programs to build more partnerships with the communities and direct their programs to create more community linkages. So now we're at priority 2.3, our third priority within this pillar, which is to build capacity by training, expanding, and diversifying the perinatal mental health workforce. So this really is all about training and workforce. So 2.3.1 is to require all relevant existing federally funded training curricula and technical assistance programs to incorporate how to prevent, screen, assess, and treat perinatal mental health conditions, inclusive of SUD and gender-based violence. So this is looking at all of the existing federal training programs and training curricula to make sure that they incorporate all of the best training program material out there. So some of the examples we give is national curriculum in reproductive psychiatry or the mother-to-baby guidance provided through HRSA, just to make sure that TA programs on mental health and substance use should always make sure this is a core topic and look at those resources to incorporate them. And then also to partner with professional societies and providers to enhance TA and creation of advisories, guides, and other publications. 2.3.2 is talking about educating future and current clinical providers in perinatal mental health conditions by ensuring that these topics are included in the curricula for both healthcare and mental health care providers. And it kind of calls out the whole spectrum of providers and in continuing education requirements. So this is talking about how federal agencies should work with medical professional societies, clinical training programs, residency training programs, graduate level programs, and make sure that from the very beginning these things are incorporated into the curriculums. And then also for every relevant certifications or board exams, initial certification as well as ongoing, that this topic there's mandatory requirements around this topic, just like they have for DEI or HIV or things like that in different boards. 2.3.2 is to educate future and current clinical providers in perinatal mental health conditions, substance use disorders, and GBV by ensuring that these topics are included. Oh, I'm so sorry, I read that one. 2.3.3 is to allocate long-term funding to establish, expand, and sustain perinatal mental health, substance use, and GBV consultation programs for medical, mental health, and substance use, nursing, and as well as other allied health providers, and non-clinical community-based workers. So this is calling on the expansion of the perinatal psychiatry access programs, and then building on existing consultation programs to make sure that they incorporate this topic. There's also other examples like the VA Reproductive Mental Health Consultation Program that we call on scaling up and continuing to fund. 2.3.4 is to fund, incentivize, and bolster recruitment and training efforts to expand and diversify the perinatal clinical and non-clinical mental health and substance use workforce, particularly in under-resourced areas. So this is a call to expand and increase funding for all federal workforce programs, such as the Minority Fellowship programs, the myriad of programs in HRSA's Bureau of Health Workforce, and to include non-clinical community-based workers and peers. So this one's really saying, okay, we need to do more. We need to have more folks in the workforce. We need to be creative. We need to think of task shifting. We need to think of all the different ways in terms of increasing the workforce. Okay, so now we are at Pillar 3, use data and research to improve outcomes and accountability. So the first priority under Pillar 3 is use data and research to support strategies and innovations that improve outcomes. And the first recommendation under this priority is to establish an interdisciplinary, interagency expert panel to determine high priority areas of research, surveillance, and implementation science that will directly affect national improvements in perinatal mental health conditions and substance use disorders. The expert panel would be charged with ensuring coordination across the federal government, translating data to action, and monitoring and sustaining research and surveillance in this area. So really, in the how section of this one, they build out a really impressive proposed national research agenda that has a range of impressive topics like augmenting research on modifiable and non-modifiable risk factors in perinatal populations, or examining the interplay between maternal mental health conditions, substance use disorders, and then physical comorbidities like hypertension, cardiac disease, renal disease, to ensure that these topics are embedded in the research, surveillance, and care models. Those are just a couple examples of what's in there. 3.1.2 is to invest in ways to build the trust of under-resourced communities who have experienced abuses when participating in research and data collection efforts. Rebuild safety by engaging communities, namely pregnant and postpartum people with higher risk, in partnerships to ensure that research, data collection, analysis, and reporting on perinatal mental health and substance use are equity-focused, representative, are culturally relevant, trauma-informed, and maintain necessary confidentiality protections with the highest ethical regard for vulnerable and under-resourced populations. So this really is also calling for an increase of perinatal populations in research in line with the PREGLAC recommendations, and calls for supporting a number of community-based participatory research efforts to help do this as well. Recommendation 3.1.3 is to support and fund integrated data systems by sharing data across healthcare and community-based services while preserving patient confidentiality. Use data to inform and drive the development of more equitable policies, effective practices, innovative interventions, and approaches to treatment and improved outcomes. So this calls on integrating data from various municipalities, counties, states, U.S. territories, and federal agencies. It also calls for experts in data modernization to be engaged to develop necessary data standards and pipelines, create repositories, warehouses, and link data. And then various models are suggested for how to do this. 3.1.4 is to increase investment in current perinatal health data collection programs and create a central clearinghouse of information so that providers, public health and government officials, and the public can quickly identify and use resources for perinatal health data. So some example programs are listed here, namely PRAMS, the Pregnancy Risk Assessment Monitoring System, and MATLINK, Maternal and Infant Network to understand outcomes associated with medication for opioid use disorder during pregnancy, managed by the CDC, of course. 3.1.5 is to create mechanisms to pair implementation guidance and dissemination strategies with research, scientific, and surveillance findings on perinatal mental health, substance use disorders, and GBV for wide use, application, and adoption of the most up-to-date interventions, guidelines, and data. So this is really to be able to disseminate research findings in a more clear way. So it's to say, use clear language and plain language to diverse audiences, including policymakers and patients and their families. So the second priority in this pillar is to build a foundation for accountability in prevention, screening, intervention, and treatment. So this one focuses all around accountability. So 3.2.1 is to establish and implement quality improvement metrics for providers, hospital systems, and insurers with multi-year longitudinal tracking of costs and outcomes, and create mechanisms to ensure implementation of evidence-based solutions. So for this effort, it's suggested that a collaborative model is formed where multiple operating divisions can engage, and that federal agencies work with others to create necessary billing codes and incentives for provider community intervention and quality improvement programs to make sure that evidence-based programs are adopted more widely. So one strategy, for example, that's mentioned is to establish HEDIS measures focused on maternal mental health and SUD outcomes, at least through the first year after pregnancy. And, I apologize. 3.2.2 is to fully fund and expand support for perinatal quality collaboratives, PQCs, fully in all 50 states, DC, and US territories, including military and veteran spaces. And then 3.2.3 is to continue to fully fund maternal mortality committees, MMRCs, in all 50 states, DC, and all US territories. So now we're at our fourth pillar, which is promote prevention and engage, educate, and partner with communities. So the first priority here is to promote and fund primary prevention strategies at the community level. So recommendation 4.1.1 talks about elevating and funding the implementation of evidence-based best practices and programs that promote person-centered, culturally relevant, and community-level detection and prevention of perinatal mental health conditions and SUDs, especially in under-resourced communities at high risk for these conditions, and ensure related Medicaid and private payer coverage. So this is talking about modeling and scaling and funding prevention programs and different tools. So it includes implementation of best practices for prevention among people who are also in the conception phase, and individuals who have experienced miscarriages, stillbirths, children in the NICUs, who have children in NICUs, and other traumatic perinatal events. So it really is talking about a fuller spectrum of what we need to do around prevention for all populations leading even up to pregnancy. It also talks about scaling up and funding models like centering pregnancy and PrEP that kind of do more primary prevention work, and also adapting other community-level detection tools and programs that we've learned in other spaces, so like the hair model, which talks about interventions in barbershops, to basically call on adapting those types of models for this population and seeing how we can implement them as well and get those funded. So the second priority in here is to elevate education of the public about perinatal mental health and substance use and engage communities with outreach and communications. So the first recommendation in this priority is to support a nationwide approach to clarifying the messaging and target audiences of all mental health, SUD, and GBV, and crisis support warm lines and hotlines for the perinatal populations and their families. So this is talking about creating a federal clearinghouse for information for all the relevant warm lines and hotlines, and making that messaging really clear about what line is for who and who can use it, and just to make that communication really clear. And then 4.2.2, the last one in this pillar, is to improve federal strategies to communicate with and engage families, personal networks, those with lived experience, and communities in conversations about perinatal mental health, substance use, SUDs, and care, with a focus on decreasing stigma, raising awareness, and addressing safety on an ongoing basis. This recommendation splits the how section into education and messaging, and then engaging, and then goes into lots more detail on how to do those. It calls for national campaigns that combat stigma, simple messaging, inclusive of creating safe spaces to talk about trauma and IPV. It also talks about working with states to enhance communications and outreach, and then calls out many available tools. Okay, so now I'd like to hand it over to Maya Meckenbauer, who to lead us through the very last pillar, the fifth pillar. Maya Meckenbauer couldn't be here today, although I know she really wanted to be. She is with the U.S. Digital Services and is the portfolio lead for a set of 3 projects focused on maternal health and early childhood under the President's Executive Order on Customer Experience. This winter, she and her team led a 6-week research sprint to better understand the lived experience of mothers as they navigate maternal mental health screening, diagnosis, and treatment from pregnancy through the postpartum period. And we're so, so grateful to have had that report be part of this national strategy. So we'll hand it to Maya. Okay.
Great, thanks, Nima. Can you hear me okay? Thank you to the HHS team for finding a way to let me participate remotely as my family juggles some health and childcare issues today. So if we could advance to the first slide. Our team's goal was to include the voices of real mothers in the administration's national strategy as one component of human-centered policy approach. Our interviews with mothers aren't meant to replace the significant amount of academic research and expertise provided by the task force. They are meant to complement this existing body of work, which was built over decades by many of you in this room, using real stories along with data to deepen our understanding of the challenges and opportunities in this space. The mothers we spoke to live in 9 different states in urban, suburban, and rural settings and had different racial and ethnic backgrounds. Many mothers had given birth to at least one child during the pandemic. Some were covered by Medicaid, some by private insurance or health exchange plans, which helped us understand how different insurance coverage might impact their care. We created a journey map based on these interviews that visualizes the challenges mothers face while trying to determine whether they should seek help, go through screening and diagnosis, and find a provider for treatment. We heard that mothers are often unprepared for the mental health challenges that they face during pregnancy and postpartum. While conditions like postpartum depression are more common in the cultural discussion now, other conditions like anxiety or obsessive compulsive disorder, for example, may be harder for mothers to recognize as valid and treatable. Mothers also shared how they felt forgotten after birth, with all medical attention now turned towards their new babies. This can leave them feeling vulnerable and unsupported during their transition into motherhood. As one mother put it, "I felt very cared for all through my pregnancy, and then I had the baby, and it was like, okay, you are done. We're done caring for you, and now it's all about the baby." I was very confused by that dynamic. Pregnancy and postpartum is also a time when a mother's health and financial stress can compound with the physical challenges of pregnancy and postpartum recovery. This, combined with the lack of sleep that accompanies newborn care, can create a perfect storm of risk factors for many women. Mothers describe the anxieties that they felt giving birth and trying to stay safe during the COVID-19 pandemic. One mother told us, "I don't have a lot of friends who are parents, and through the pandemic, it was very scary to go in for appointments, ultrasounds, and to see the doctor. My husband wasn't allowed to go with me to a single appointment." Mothers told us how the pressure to be a good mom might cause them to ignore mental health warning signs because they worry about how they might be perceived for seeking treatment by family, friends, or their healthcare providers. Breastfeeding in particular came up again and again in our interviews. One mother told us, "I consider myself a feminist. I couldn't let it go that I thought other mothers could do this easily. If I was a good mom, I could do it. Why can't I?" We also learned that mental health screening tools can create more anxiety and undermine trust if they are not delivered with care. Many mothers felt there was no context setting or a conversation about why they were given a screener and what would happen afterward if they scored too high. Screener questions tended to not match the way that mothers would describe their own experience, and their responses are influenced by their own desires and fears about being perceived as good mothers. Additionally, the mothers of color that we spoke to expressed a heightened sense of fear due to their perceived pressure of needing to show even more competence as a mother. One mother described the screener as the form we all lie on. Even where mothers may identify their own risk or score high on a screener, they face numerous barriers to seeking and receiving care. It is hard to find a provider who is affordable, who you connect with, who has availability, and who you can get to, given your work and childcare obligations. Some of the mothers we spoke to tried to receive care and then eventually gave up. Those with Medicaid had an even harder time finding available quality providers who accepted their coverage. And finally, returning to work before they were ready was a major trigger for mental health challenges for the women we spoke to, particularly in a country where there is no guaranteed paid parental leave. Many of the mothers we spoke to described how their need to return to work meant they had to sideline their own recovery, as well as the needs of their growing baby, in order to keep their households financially afloat. As one mother put it, "At 4 months, your child is not sleeping, you are not sleeping, you're a zombie at work, but you're still expected to show up in a certain way." Can we turn to the next slide, please? Still, there were some important bright spots and opportunities from our interviews. We heard that when providers, whether a doctor, nurse, a midwife, or a doula, took the time to ask mothers about their mental health and connected them with resources, they were more likely to be correctly diagnosed and receive appropriate care. This may seem obvious, but it's worth stating because it's not happening nearly often enough. Finding more ways to extend care teams through group and peer support models could help provide much needed community as mothers grow into their new role. Doulas and midwives were cited repeatedly as key providers that made a difference in mothers' experiences. When care teams are diverse and reflect the communities they serve, mothers report a higher level of trust. Screenings can be conducted in a way that is part of an interpersonal conversation, less like an exam that you could pass or fail, and with more context about the purpose and what comes next for the mom. A more conversational approach could help make screening more effective at identifying risk. A digital screener with more user-friendly language could also be helpful for mothers who aren't making it into appointments, or who may feel more comfortable completing it at home rather than in a crowded waiting room where they're also juggling their new baby. Mothers' experiences, needs, and contexts vary, and our healthcare system should reflect that reality with multiple ways to get screened and treated. And of course, paid parental leave is necessary for American families to take care of their babies and themselves. Too many mothers are returning to work after just a few weeks, when they and their babies are incredibly vulnerable and they are still healing. The mental health impact of having to leave your baby and return to work before you're ready cannot be overstated. 3 US studies have found that extended maternity leave was significantly associated with lower cases of postpartum depression. And if we can turn to the last slide. Here, the HHS team has mapped the recommendations generated by the mothers we spoke to the priorities outlined in the national strategy. The lived experience report describes just a handful of experiences, but millions of mothers are going through similar journeys every day as they expand their families. The mothers we spoke to bravely shared their personal stories in the hope of helping more families avoid the challenges that they faced. Together, we can make all their voices count through our collective action. Thank you for being here and for all the work that you're doing. And now I'll hand it over to, I believe, Crystal McCauley, who is going to share her personal story.
Thank you so much, and thank you for the invitation to share my personal story today. My name is Crystal McCauley, and in January 2007, I moved from North Texas, where I grew up, to Northern California to further pursue a career in the wine industry. I'd been managing a wine program in Dallas, and when the opportunity to work for the Wine Studies Department of the Culinary Institute of America presented itself, I could not pack my things fast enough. As many young Americans do, I moved myself across the country to pursue a career opportunity. After 2 years in California, I met my husband. We moved to his native New Zealand for several years and ultimately came back to California, where we were married in 2010. We were excited to build a life together. In 2014, we welcomed our first son to the world, though his birth did not go as we planned. He was born via emergency C-section, and joy of the birth of a healthy child was deeply overshadowed by the dismissive, disrespectful, and lacking maternity care I received throughout both his induction and his birth. 18 months later, we welcomed his brother via a VBAC, a vaginal birth after cesarean, and the maternal mental health complications that were to come would fundamentally change who I am as a human being. I initially thought the inability to sleep for days at a time was an adjustment to motherhood with 2 babies. Something in my mind assumed that not sleeping was just part of parenting, and I ought to get used to it. The problem was I felt wired all the time. I was on high alert, and like I was being evaluated by some outside source that saw what a terrible, incapable mother I was to my children. As the days of not sleeping wore on, I became increasingly paranoid. My appetite disappeared. I lost so much weight that I had to buy new clothes, and a dangerous cycle for anyone who has experienced an eating disorder like I previously had before knows all too well. Body image issues I had once considered a thing of the past resurfaced with a vengeance. Then all the pride I felt in my professional life was soon to be lost when I realized I could not perform my job as I had before. Going back to work would not be an option for me for some time, as I was terribly sick with maternal mental health challenges. Although it would take many months, eventually I was diagnosed with a swath of maternal mental health complications, including postpartum depression, postpartum anxiety, and perinatal OCD, or obsessive compulsive disorder, which for me presented with suicidal ideation, as well as intrusive, unwanted thoughts, which are experienced by up to 98% of the perinatal population. Prior to becoming parents, we'd purchased a home that was financed on 2 full-time incomes, a purchase I did not hesitate to make while pregnant, because even though I was going to be a mom, I was always going to be a working mom. Not only did we rely on 2 income contributions, but work was personally fulfilling for me as well. After both deliveries, I was able to take 12 weeks of job-protected leave from work, and due to California's paid family leave benefit, I was able to access 8 more weeks of time to bond with each of my newborn children. My husband was able to access 8 weeks of paid family leave bonding time as well after each birth through California's paid leave benefit, which he split up over several weeks in order to accommodate my easing back into work. The paid leave provided us the time to heal in order to return to full capacity, which seems like the very least we should be doing for anyone who's just given birth, let alone the 1 in 5 of them who will deal with a maternal mental health issue. Sadly, these outcomes are not echoed by the friends I grew up with in Texas, who gave birth and then were required to go back to work at full capacity on the very day that their 12-week job-protected leave expired, or faced punishment, or worse, the possibility of losing their job. Additional time to heal, physically or mentally, was never going to be on the table for those working moms. The depths of despair eventually led me to new work. I began volunteering as a peer supporter, holding space weekly for new and expectant parents alongside a perinatal therapist in my community. I engaged in state advocacy, first as a volunteer and eventually as an employee. I'm proud to have been part of the team that helped pass critical state legislation in California, like the maternal mental health screening mandate, which requires OB providers to screen mothers during pregnancy and during the first year postpartum with a no wrong door access policy. I would like to thank all the advocates who worked tirelessly to see the Triumph for New Moms Act was supported by their legislators. Your voice matters so much. Thank you to the task force for your important and ongoing work. This is a club I never wanted to be a part of. But if you have to become part of this club, I can tell you, I have never been loved more completely than I have been by the others who have walked through this same fire. Maternal mental health complications are temporary and treatable, but there is so much hope, especially when we work together collaboratively. Thank you. I'll pass it back to Dr. Fink and Dr. Sheff. Thank you so much.
Great. Well, thank you all. I think I have my voice back, so I'm back in good shape here, hopefully to wrap things up. We want to, again, thank you all for your time today. We couldn't be here without all of you through sharing your stories, through working so hard on the task force. It's really been an incredible effort across so many different groups. As we think about the next steps, you can see here we'll be next looking at the implementation phase of the task force. And so lots of really great work to come. We will be also working on the report to governors and looking at annual updates to both the report to Congress and the national strategy. With that, I'll turn it over to Dr. Sheff.
Thanks, Dr. Fink. So, again, we just want to reiterate our gratitude to all the task force members. You know, you haven't just contributed to this work, you really owned it. Like, you really have. And it's so clear that this has been your life's work, I mean, for most of you. And it's just been such a privilege to be in these spaces with you all. And we're really excited to continue, being in these spaces with you till hopefully past 2027. And then we're especially grateful to all the mothers with lived experience that, who have lent their expertise and experience to the task force. It's your stories and experiences that really give the national strategy life and real meaning, because or else it's just words on a page. It really is. And so we just really, really want to thank you for that. Again, want to thank all of our leadership and everyone that was mentioned today, our other federal agency leadership, the co-chairs of this task force, everyone. And then lastly, we just want to remind everyone we're totally just getting started. So this is the beginning, so stay tuned. We're not letting anyone go. And with that, we'll close out. So thanks so much, everyone.
Produced by the U.S. Department of Health and Human Services.